I'm Max Feinstein, and this is managing anaphylaxis in the operating room. Hey Bob, I've got some oxygen for you to breathe before you go under anesthesia. Just go ahead and take some nice deep breaths. Bob, you're doing a great job taking those deep breaths, and I'm going to give you some nice relaxing medication through your IV. Keep focusing on those nice deep breaths all the way in and out. All right, Bob, I'm going to go ahead and start giving you the medication that's going to have you go all the way under anesthesia. Sometimes it feels a little warm in the IV, and soon you'll drift off to sleep. All right, there's a lot going on in this video, so we're going to break it down piece by piece, starting at the beginning. I'm Max Feinstein, and this is managing anaphylaxis in the operating room. I don't usually have entrance music for myself on my YouTube videos, but thought I'd try something new, see if it gets the people going. So right off the bat, you're going to notice that on the screen that has all of our monitors up here, we've got an arterial line. This gives us a blood pressure reading, systolic, diastolic, mean blood pressure, just like you'd get on a non-invasive blood pressure cuff that would go on a patient's arm or leg. But an arterial line is going to give us beat-to-beat blood pressure monitoring, so we can continuously see what a patient's blood pressure is. There are a number of different reasons that we might place an arterial line in a patient for surgery, which could include a patient being very sick, so we need to keep a very close eye on their blood pressure, or we anticipate it's going to be a very long and involved surgery for which we would want to be able to monitor their blood pressure very closely, or we would anticipate giving blood transfusions, needing to get labs drawn fairly frequently, get arterial blood gases during the case. There's some other reasons too, but you already know without seeing any more information about the patient that either this patient is quite sick and or this is a pretty big surgery, that the patient's already got an arterial line in place before the induction of anesthesia. Hey Bob, got some oxygen for you to breathe before you go under anesthesia. Having patients breathe 100% oxygen prior to the induction of anesthesia is a process called pre-oxygenation or denitrogenation. Normally, the air that we're breathing contains about 21% oxygen, and the majority of the rest of it is nitrogen. But if we want to increase our margin of safety after we induce anesthesia, but before we've got an endotracheal tube in place, then the process of pre-oxygenation is going to give a longer period of time before a patient desaturates, meaning they don't have enough oxygen going through their blood. Just go ahead and take some nice deep breaths. And I always go over a checklist in my head to make sure I've got all of the equipment necessary prior to the induction of anesthesia. You've probably seen this on my channel before. This is the MS MAIDS mnemonic, where I look at making sure that I've got my anesthesia machine, S for suction, the next M for monitors, which we've already seen on the screen above, A for airway, so I've got a McGrath MAC 3 blade right here, an endotracheal tube, and then also a direct laryngoscopy MAC 3 blade, IV equipment, which is already plugged into the patient in this case, and drugs. So we'll get into the drugs shortly, but you can see here that we've got fentanyl, propofol, and rocuronium as part of our induction strategy. You can also appreciate on the screen, looking at our ventilator, that the patient has tidal volumes that they're taking. Unfortunately, when I was doing this simulation, it didn't capture very well, but you would expect to see tidal volumes that are approximately 10 milliliters per kilogram of body weight for a patient. So for a 50 kilogram patient, I would hope that they're taking tidal volumes of at least 500 milliliters, hopefully more, during this process of pre-oxygenation. Bob, you're doing a great job taking those deep breaths, and I'm going to give you some nice relaxing medication through your IV. There are a number of different medications that anesthesiologists can use to help patients feel relaxed prior to the induction of anesthesia or as part of the induction of anesthesia. In this particular case, I have elected not to use one of the common medications called midazolam, which is a short-acting benzodiazepine. I'm imagining in this case that this patient might be older, and midazolam is something that I typically avoid in patients who are older because that can contribute to delirium postoperatively. So in this case, the relaxing medication that I'm giving is the opioid called fentanyl, which is actually part of the induction strategy because fentanyl, with a peak effect time around 4 to 6 minutes when administered IV, is going to help decrease the patient's response to laryngoscopy, which is the process of having the endotracheal tube placed, which you'll see shortly. Here I'm checking to make sure that the IV that I'm using is running quite well. And you can see the IV tubing right up here is dripping quite nicely. So I'm getting that going at a rate that I'd like for my induction. Keep focusing on those nice deep breaths all the way in and out. I'm constantly scanning the room and looking especially at the patient's vital signs, the EKG tracing, their heart rate, blood pressure, oxygen saturation, to make sure that everything looks like the range that I want it to look like. You can also see on the monitor here that I've got a readout of the patient's end tidal oxygen, which is to say what percentage of the gas mixture that they're exhaling is made up of oxygen. In this case, we've got an end tidal oxygen of 73%, which is pretty good after 30 seconds of pre-oxygenation. Ideally, I'd like to get that into the 80 or 90% range if possible. Now I'm preparing to administer propofol to this patient, and imagining that this is an older, sick patient, I'm not going to give a particularly large dose of propofol, which has an effect of vasodilation, which means increasing the size of the blood vessels, which will then have the effect of dropping a patient's blood pressure. So it's very common to see a decrease in blood pressure on induction of anesthesia, but you can mitigate that effect by giving a lower dose of whatever induction agent you're using, but you just have to make sure, of course, that you give enough of an induction agent that they're actually under general anesthesia prior to placing a breathing tube or having surgery start. All right, Bob, I'm going to go ahead and start giving you the medication that's going to have you go all the way under anesthesia. In this case, I gave 5 cc's of propofol, which is 50 milligrams of propofol. Let's assume that this patient weighs 50 kilograms, so that ends up being 1 milligram per kilogram. That's a relatively small dose of propofol that you have to make sure that you are giving an appropriate amount of other agents. And in this case, I gave a fairly large dose of fentanyl. Sometimes it feels a little warm in the IV, and soon you'll drift off to sleep. It's always important to let patients know what they can expect to feel, and propofol does sometimes feel warm or it even burns a little bit as it goes into an IV, so I always make sure to let patients know that so there are no surprises. Again, I'm panning up and looking at my monitors and making sure that everything is exactly what I want it to be. Ideally, I would have gotten the end tidal oxygen concentration a little bit higher, but this is a mannequin and it doesn't work perfectly well, so I took 70%. The simulator is very lifelike. I pre-programmed it before I ran this simulation, so that's why it ended up closing its eyes, because I had the timing down for a few seconds after I administered the propofol. With the patient now under general anesthesia, I'm going to administer rocuronium, which is a non-depolarizing neuromuscular blocker. Paralytics like rocuronium only affect voluntarily controlled skeletal muscle and does not affect cardiac muscle or smooth muscles that are involuntarily controlled, like those that are in our arteries or in parts of our GI system, for example. The reason that we administer neuromuscular blockade for patients under anesthesia is because it has the effect of relaxing the vocal cords. So it makes it easier and safer for us to place a breathing tube which goes between the vocal cords. Muscle relaxants also make it a lot easier for surgeons to operate on patients who aren't moving. Because as you can imagine, if a patient is twitching a little bit, even though they're completely under general anesthesia, that can make it more difficult for the surgeon to operate. And you can appreciate that the patient went from breathing on his own, where he was taking a breath every few seconds, to no longer breathing, which is a combination of the effects of fentanyl, propofol, and then of course the rocuronium, which we just gave. Because the patient is no longer breathing on his own, I go ahead and take over breathing by squeezing this bag, which is connected to our breathing circuit, which ultimately goes to the face mask that connects to the patient's lungs. So every time I squeeze the bag, the patient's lungs are being inflated with the gas mixture that I've dialed in on the ventilator, which in this case is oxygen that's at 100%. I always look at the patient, not just the monitor, because I want to make sure that the chest is rising every time I deliver a breath. It's really important to correlate whatever you're seeing on your monitors and whatever lab values you see with what you actually see with your eye looking at the patient. Now I'm correlating with the monitor and making sure that I'm delivering appropriate tidal volumes to this patient. 175 is lower than I would like, but again, it's an artifact of the simulator. In real life, for a patient like this, the tidal volume that I'd be delivering by hand would probably be about 500. And again, I'm always sweeping with my eyes and looking at the vital signs and seeing what changes are occurring. You can appreciate that the patient's heart rate has gone up to 91 now. The blood pressure has started to decrease a little bit, which is not surprising given that we talked about how most anesthetic agents, especially propofol, are very vasodilating, so that does have the effect of decreasing the blood pressure. But like I said, I tried to mitigate that with a relatively smaller dose, so hopefully the blood pressure decrease won't be too significant here. The increased heart rate is most likely a compensatory mechanism for the decrease in blood pressure. The body tries to keep the blood pressure at a normal level, and when it can't do that, blood pressure goes down, then heart rate typically will go up so that the total amount of blood being ejected by the heart remains the same. Part of the reason that I'm continuing to wait right now is because it does take a couple of minutes for rocuronium to completely exert its effects. Because this is a simulated video, I did cheat a little bit and jumped probably a minute ahead. In real life, I would have waited longer for the rocuronium to fully take its effect. And now I'm reaching for my intubation equipment, and for this video I've chosen a video laryngoscope called a McGrath, which is especially helpful for this type of simulation so that you can see exactly what I'm seeing on the screen in here. And I've also got my endotracheal tube with a stylet in it to help maintain its rigidity. As I'm doing this intubation, the anatomy that you can observe are the patient's arytenoids. This is the patient's right vocal cord. It's at a slightly lighter color than the tissue around it. And then this is the glottic opening. This is exactly where I need to put the endotracheal tube. And you can see that the epiglottis just flopped down into view. In real life, the epiglottis is actually pretty easy to move out of the way with a Macintosh blade like this, but with the mannequin it gets a little more difficult, but we'll get the intubation nevertheless. This is really important to appreciate, seeing the tip of the endotracheal tube going through the glottic opening, so there's no question in my mind that this endotracheal tube has ended up in the trachea as opposed to the esophagus. Getting the endotracheal tube in the esophagus is commonly referred to as goosing the tube, and that's never helpful for a patient. I remove the stylet. I connect our circuit to the endotracheal tube. I'm inflating the pilot balloon. And the first thing that I do is squeeze the bag to make sure that I'm actually getting tidal volumes that I see in tidal CO2, which should show up here shortly. And you can see that I do have some air movement down here. I still don't see a CO2 tracing, which is what the patient is breathing off, which is just another confirmatory way that I have to make sure that the patient is intubated. But now I'm concerned because you can hear that the oxygen saturation has started to drop, and you can see that it has dropped a little bit. But perhaps more concerningly, the patient's blood pressure has started to drop to a pretty low level. I'm trying to squeeze the bag, and I'll tell you right now that I was having a very difficult time squeezing this bag. And you'll appreciate that there is still no end tidal CO2, meaning I don't detect any CO2 that the patient is breathing off. This is very concerning for me and makes me think that there are any number of problems that have potentially just started to come up. Because I don't know exactly what's going on, but I've noticed in the last few seconds that the heart rate is increasing, the blood pressure is dropping, I'm having a difficult time ventilating the patient, I don't see any end tidal CO2, I'm going to get my stethoscope immediately and take a listen to the patient's lungs to see if I can get any clues as to what might or might not be going on right now. What I'm doing here is squeezing the bag that's connected to the circuit, which is connected to the endotracheal tube, which should be connected to the patient's trachea and lungs. So when I'm listening, I should be able to hear movement of air. And depending on what I hear, that's going to point me in one direction or another to figure out what exactly is going on right now. You may have heard the expression that anesthesia is 98% boring and 2% sheer terror. I take issue with the idea of sheer terror because after you've gone through training and you've taken care of enough patients and you've passed your board exams, you shouldn't be terrified of any kind of situation, but instead you should be ready to build up a list, or a differential as we would say, of what the possible problems are in any sort of situation where it seems like something is wrong. So in this situation, I've already started to build up a mental list in a very short period of time of what might be going on. This patient might be in a condition called bronchospasm. It's possible that there's a problem with the actual physical connection of the endotracheal tube. Sometimes plastic wrapping can get caught in between the endotracheal tube and the rest of the circuit. That's the kind of thing that I'm thinking about. This could be an anaphylactic reaction to a medication, which you might have guessed based on the title of this video. I might be thinking about a lung condition called a tension pneumothorax. All of these conditions that I just mentioned can lead to the clinical picture that we're seeing now. So taking a listen to the patient's lungs is probably going to help me figure out what might or might not be going on so that I can start treating whatever problem's occurring right now. If this patient is having anaphylaxis, then one of the things that I would expect to hear is wheezing. And so indeed, for this simulation, that's what I heard, and immediately makes me think that one of the medications that I gave is causing anaphylaxis, and that is the reason why the patient has dropped their blood pressure, dropped their oxygen saturation, and gone into probable bronchospasm where they're not able to expand their lungs at all. This medication that I always keep nearby on hand is epinephrine. It's important to know when you have epinephrine available, what concentration it is, and what delivery route you can give it. Because if you don't have IV access, then the alternative is giving intramuscular epinephrine. So I tend to keep both 100 microgram per ml dilution and a 10 microgram per ml dilution because I am a pediatric anesthesiologist. So I have a lot of flexibility in terms of dosing depending on a patient's weight. In this case, I'm starting off with a dose of 50 micrograms. So I delivered 5 milliliters of 10 micrograms per ml epinephrine. This would be a starting dose for treating anaphylaxis in an adult. You can appreciate that in a very short period of time, the patient's blood pressure went down to such a low level that it's basically not compatible with life anymore. And we don't even have an oxygen saturation reading, which is probably a result of the fact that the blood pressure is so low that there's not enough pulsatility across the capillary bed where the oxygen saturation is being picked up, presumably on the patient's finger. The patient's heart rate is very high, which again is probably a compensatory mechanism for such a low blood pressure. In this situation where a patient has gone from being awake and in good physiologic condition to now being under general anesthesia and having the blood pressure basically in the toilet, it's so important to make sure that you've called for help, that you have additional hands to help do procedures, push medications, and additional minds to help think through and treat what might be happening right now. I'm continuing to squeeze the bag and let a little bit of time go by because it does take a little bit of time for the epinephrine that I injected into this injection port here to travel down the IV tubing into the patient's blood and then be circulated through the patient's body. Keeping in mind that this patient's blood pressure is especially low right now, I assume that it's going to take an extra long period of time for the epinephrine to actually circulate through their blood. I'm taking another listen with my stethoscope to see if anything has changed with their lung sounds. And again, I'm just letting a little bit of time go by to let the epinephrine circulate. And right here you can catch just the tiniest blip of CO2, which means the patient is now actually exhaling CO2, and that's being picked up on my capnogram right here on the ventilator. This gives me the first glimmer of hope that the epinephrine that I've administered is treating a problem that here I'm assuming is anaphylaxis, but could also be any number of other issues. And here we've got a much higher blip of CO2 that's being shown on the capnogram here, which gives me more hope that we did indeed treat whatever problem we're dealing with right now. So now you can appreciate the patient's blood pressure is quite high, but in this case, I don't mind having a robust blood pressure because they just had such a low blood pressure that I want to make sure there's adequate perfusion to all of the tissues in the body. You can see that we now have a reading on our pulse oximeter here, 65%, not a particularly high reading, but at least it's a reading, whereas before we didn't even have enough of a blood pressure to generate a reading. And we can see on our ventilator that we do have some tidal volumes being produced, which is great because that tells us that there is gas exchange occurring between the lungs and the ventilator. And again, we've got end tidal CO2, meaning the patient's breathing off CO2, another reassuring sign that we're moving in the right direction. I'm also looking at the patient to clinically correlate my findings with the ventilator to see that their chest is actually rising, that I'm moving air that the patient is getting into their lungs. Now, Bob is made out of plastic, so his skin is not going to change. But in real life, I would be looking at a patient's chest, at their face, and see if there's any evidence of a rash that would point me in the direction of anaphylaxis. The patient's oxygen saturation continues to come up, so this is great news. And if this were anaphylaxis in real life, I would probably notice that it's a lot easier to squeeze the bag to deliver air to the patient's lungs, which are no longer constricted like they were before. You'll notice that the IV is dripping at a very fast rate, which is what I wanted to make sure that the epinephrine that I injected was delivered to the patient as expeditiously as possible. Now I'm just looking at all of the vital signs and looking at the ventilator again. Patient's heart rate is high, but that's fine. I would expect that after administering epinephrine. The blood pressure is robust. Again, I would expect that after giving epinephrine. Oxygen saturation is now 100%. Excellent. And on our ventilator, we've got reliable tidal volumes and in-tidal CO2. We haven't turned on any maintenance anesthesia at this point because we've been dealing with an emergency, and the induction dose of fentanyl and propofol that I gave almost certainly means that this patient is still under general anesthesia, so I'm not worried that they're awake or feeling anything that's going on. But this would be the point, once everything is all resolved, that I would turn on the maintenance anesthesia so that the patient stays under anesthesia. Or if the decision is made to wake the patient up and cancel the surgery, then I would of course have to reverse the neuromuscular blockade and then proceed to wake them up. So here I've just turned on my ventilator because I was bagging by hand previously. And my chief differential here, meaning what I'm thinking happened that's most likely, is the patient had an allergic reaction to rocuronium. Paralytics are one of the two major categories of medications that causes anaphylaxis in the operating room. The other major category of medications is antibiotics. So any time that a patient has significant changes in their hemodynamics after receiving either neuromuscular blockade or antibiotics, one of the first things that I'm thinking about is anaphylaxis. Now, if this did happen in real life, then within an hour, I would draw and send off a lab called a tryptase, which would indicate whether or not an anaphylactic reaction had occurred. If that lab is normal, then I wouldn't be concerned that the patient had anaphylaxis, and we would have to investigate other reasons for this hemodynamic collapse. But if they did have a high tryptase level, then I might think about sending the patient to an allergist to get tested for allergic reactions to the various medications that are used in anesthesiology so that they know in the future that they have an issue. If you enjoyed this video, you might want to check out this video I made where I run through step by step what happens in a pediatric emergency under anesthesia. Thanks very much for watching. I'll see you next time.